Okay, so now we're going to talk about potassium. So normal lab values should be 3.5 to 5 milliequivalents per liter. It's mostly found inside the cells. It's responsible for neuromuscular function. It transmits nerve and other electrical impulses. It regulates acid-base balance, and hydrogen and potassium ions shift back and forth between ICF and ECF to maintain the pH. Hydrogen is the acid, so in alkalosis, hydrogen moves out of the cell to correct the high pH, and so potassium goes into the cell. And then in acidosis, potassium moves out of the cell while hydrogen moves into the cell. Sodium-potassium pump regulates it. Remember aldosterone with this. It will increase when pH is low, so it shifts out of cells into the extracellular fluid to raise the levels. Adequate intake is between 40 and 60 milliequivalents per day. For functions in the extracellular fluid, it maintains action potentials in excitable cells of muscles, neurons, and other tissues. It assists in controlling cardiac rate and rhythm, conduction of nerve impulses, skeletal muscle contractions, and functions of smooth muscles. In the intracellular fluids, it has a role in cellular metabolism, functions in regulation of protein and glycoprotein synthesis. It has some control over intracellular osmolarity and volume via the sodium-potassium pump. So with hyperkalemia, that's too much potassium, it's rare with healthy kidneys. When potassium moves into the cells, it increases excitability. Cells respond to less intense stimuli or even without stimulus. Myocardium is most excitable and most sensitive to increases. Some most common causes for hyperkalemia are kidney failure, use of supplements, receiving old blood, cell destruction such as trauma or burns, can get false highs by improperly taking the specimen, just keep that in mind. Acidosis, hydrogen moves into the cells while potassium is moving out, and then potassium-sparing diuretics. Some signs and symptoms. So a good way to remember some is the word murder. So muscle cramps, urine abnormalities, respiratory distress, decreased cardiac contractility, EKG changes, and reflexes. So changes in the EKG, irregular heart rate, or bradycardia. Again, signs and symptoms: hypotensive, cardiac arrest, hyperactive bowel sounds, diarrhea, abdominal cramping, nausea, vomiting, muscle twitching, weakness. So with assessment, you want to have a cardiac monitor to EKG changes, serum potassium levels, eyes and nose. Adequate renal failure is needed for potassium excretion. I don't think that meant renal failure. Adequate RF. Have to look that up. So you want to identify the risks and causes. So there's aging, decreased kidney function. There's dehydration, there's diabetes or renal failure, there's traumatic injury, meds that increase dietary, so like potassium-rich foods, salt substitutes, potassium supplements. So for treating this, we want to decrease the potassium intake. So stress the adherence to prescribed restrictions. No potassium supplements. Refer to a dietitian for most of that. Promote excretion. Kayexalate enema or orally exchanges sodium with potassium in the GI tract, so then it has potassium-rich diarrhea. Then there's IV medications, so regular insulin and glucose IV, calcium gluconate decreases, potassium wasting diuretics, 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 potassium was loop diuretic, Lasix if kidneys are working, thiazide diuretics, stop potassium supplements, avoid foods high in potassium, and then there's dialysis if it's really severe. Next, we're going to talk about hypokalemia. So this is not enough. Some causes for this might be inadequate intake, use of potassium wasting diuretics, starvation, high glucose levels leading to diuresis, excessive secretion of aldosterone leads to potassium excretion from the renal tubules, renal disease, which affects the resorption of potassium, excessive GI losses from nausea and vomiting, nasogastric suctioning, diarrhea, meds that are diuretics or corticosteroids, and then to compensate in metabolic alkalosis, the potassium moves into the cells as hydrogen moves out of the cells. So, manifestations of hypokalemia most develop below 3.0 milliequivalents per liter unless it's a rapid drop. For the cardiovascular, there's variable pulse rate, weak thready pulse, decreased blood pressure, and ECG changes. Decreased and shallow breath sounds, dyspnea. For renal, there's polyuria, nocturia, decreased SG, if severe, myoglobin in urine due to breakdown of muscle. Neuromuscular, there's decreased deep tendon reflexes, muscle weakness, paresthesias, leg cramps, soft, flabby muscles, and coma. For GI, there's nausea, vomiting, diarrhea, distension, constipation, ileus, decreased absent bowel sounds, and polydipsia. For assessment, we're going to be looking at labs, looking at the potassium levels, obviously. Elevated pH and bicarb levels, they support alkalosis. Decreased serum chloride levels. Decreased magnesium. Magnesium can potentiate hypokalemia. Decreased calcium may accompany all three must be restored. ECG changes, have a cardiac monitor. Trend changes to monitor therapeutic treatment. Vital signs, especially orthostatic blood pressures and respiratory rate, depth, and pattern. Electrolyte levels. I's and O's. Diuresis can lead to excessive loss of potassium because that's how it's excreted. 1 liter of urine contains about 40 milliequivalents of potassium. Identify risk changes or risk factors such as aging, medications, alcoholism. Monitor your intake of foods that are high in potassium. So for hypokalemia treatment, there is replacement therapy, diets high in potassium foods, there's consult dietitian for more, dietary supplements, especially if they're on potassium wasting diuretics. If there's a poor nutritional intake, you need to figure that out. If there's a disease process that's causing low potassium levels, there's medication therapy, so prophylactic dose in 20 milliequivalents daily. There's liquid or pill form. With potassium administration, there's oral, so you want to take with at least 4 ounces or 120 milliliters of fluids or with food. Do not use salt substitutes because that is potassium, so you could be changing that there. Dissolve powder form in 4 ounces of water or juice, but no carbonation. For IVs, you never give IV push. You place on a cardiac monitor per your hospital's policy. You're going to assess the IV site very often because it can, especially if it infiltrates, it will burn. Always dilute. You can give 20 milliequivalents riders slowly, and you can add 40 milliequivalents to a liter bag. So some extra things to touch on. Potassium is excreted through the urine. Again, you do not push potassium IVs. Hypokalemia, smooth muscle shuts down, so just need to remember that. You're at risk for hypokalemia with metabolic alkalosis because the potassium shifting and then the NG tube sectioning as well. And I think those are all the things that I wanted to touch on.